Medical Coding Review. By now, you've learned all about medical coding and should be ready to take our review quiz. Before you do, use this course review to brush up your skills and knowledge.
By now, you should have a decent grasp on the basics of medical coding practice. Before we wrap up this section with a quiz, you can use this course to review some of the basic information we've covered. Let's begin the review. International Classification of Diseases, 9th Revision, Clinical Modification, ICD-9-CM. ICD-9-CM is the primary diagnostic code set in use in the United States today. Despite being more than 10 years out of date, it's still the primary way coders represent illness and injury in a patient. It's used in the reimbursement cycle to demonstrate medical necessity. That is, ICD-9-CM codes show the insurance payer why the provider had to perform a certain medical service. ICD-9-CM codes are 3 to 5 characters long and are primarily numeric. The code set is divided into chapters, each of which focuses on a certain type of illness or injury. For example, Chapter 1 contains diagnosis codes for infectious and parasitic diseases. Chapter 2 contains codes for neoplasms. Chapter 5 has codes for mental disorders, and so on. The first 3 digits, with the exception of E codes of an ICD-9-CM code, is called the category. There's always a category in ICD-9-CM. The category describes the general type of injury or disease that's being described in the code. A decimal point follows the category. The digit after that is called the subcategory. The subcategory provides additional information about the illness or injury described in the category. What type of disease is it? What type of injury? The final digit in an ICD-9-CM code is a subclassification. This further expands on the subcategory and provides even more information about the code. A subclassification might provide information on where an injury is or what may have caused the diseases described in the category. There are alphanumeric codes in ICD-9-CM. These are called E codes and V codes, as they begin with those letters. E codes describe external circumstances, such as car accidents that cause the injury. E codes are the only ICD-9-CM codes that have a letter and then 3 digits in the category. V codes, on the other hand, describe external circumstances that are not life-threatening or injury or disease-related that nevertheless cause a person to go see a healthcare provider. One such example would be a family medical history of a particular disease, or exposure to a disease-inducing chemical at a workplace. ICD-10-CM. ICD-10-CM is the update to ICD-9-CM. Published by the World Health Organization, WHO, in 1999, it features a revised format and more than 4 times as many codes as ICD-9-CM. Its organization and format is based on ICD-9-CM, but is different enough that a major training movement is underway to prepare the medical industry for the shift from ICD-9-CM to ICD-10-CM in October of 2014. ICD-10-CM is 3 to 7 characters long and is entirely alphanumeric. Like ICD-9-CM, it's organized into chapters or sections based on the type of disease or condition shown in the diagnosis. For instance, Chapter 1 in ICD-9-CM is now the set of A through B codes, A00 to B99, certain infectious and parasitic diseases. ICD-10-CM codes all have 3 character categories and 1-digit subcategories. The subcategory once again follows the decimal point after the category. ICD-10-CM codes feature up to 3 subclassifications. These extra subclassifications allow ICD-10-CM to feature much more specific information about the disease or injury described in the diagnosis. ICD-10-CM, for example, has codes for laterality, which side of the body the injury or illness is on. ICD-10-CM codes also feature alphabetic extensions. These extensions can only occupy the 7th and final character of an ICD-10-CM code and describe the episode of care for the injury or illness. In other words, extensions show which visit this is for a particular condition. These may be broadly divided into categories of initial encounter, the first visit for a condition, subsequent encounter, a follow-up for the same condition, or sequela, a visit for a condition stemming from a prior condition. Extensions are typically used in codes for injury and codes for childbirth, though they may show up elsewhere. In the case of adding an extension to a code that does not go to the final subclassification, codes use placeholders, typically the letter X. Why are we switching from ICD-9-CM to ICD-10-CM? Put simply, ICD-9-CM is out of room. As medical technology advances and we're able to make new, more nuanced diagnoses, we need a code set that is more adaptable. ICD-10-CM has more room for new codes, and its focus on specific iterations of certain conditions make it a far more data-rich code set for health organizations, health providers, and insurance companies. Additionally, the rest of the world is already using some version of ICD-10-CM. This means that tracking health data from diagnosis in the US is a difficult task. Upgrading to ICD-10-CM means the United States will once again use universal diagnosis codes. Crosswalking. We transfer between ICD-9-CM and ICD-10-CM through a process called crosswalking. Crosswalking entails the mapping of similar information across similar but distinct datasets. You can think of translating between two languages as a sort of crosswalking. Bread in English is pan in Spanish. You can crosswalk between any two code sets, but for the sake of simplicity, we'll confine it to ICD-9-CM and ICD-10-CM. Crosswalking entails finding exact, approximate, or appropriate matches between the two code sets. Since there are far more codes in ICD-10-CM than ICD-9-CM, it's generally much easier to find an appropriate match for an ICD-9-CM code in ICD-10-CM than the other way around. We call the code in the first set the source, and the code to which will match the source the target. When crosswalking, you may go from the specific to the general, but you may never infer specific information from a general diagnosis. That is, you could crosswalk a diagnosis of closed fracture of distal phalanx of great toe on the left foot to fracture of distal phalanx of great toe, but you can never crosswalk those diagnosis codes in the opposite direction. Crosswalking is not an exact science. Less than a quarter of ICD-10-CM codes have exact matches in ICD-9-CM. The goal of crosswalking is to facilitate the transfer between these two code sets and allow better data tracking. In order to assist coders, the National Center for Health Statistics, NCHS, has created a set of general equivalency mappings, GEMs. These list appropriate matches between the two code sets and are invaluable resources as you move further in crosswalking. Current procedure terminology, CPT. ICD codes describe the why of a medical procedure. CPT codes describe the what. CPT codes correspond to almost every medical procedure performed by a healthcare provider and are the primary way that providers inform payers of their services. CPT codes are divided into three categories. These categories are different than the categories in ICD, of course. CPT categories refer to the division of the CPT code manual. Category 1 is a larger and more important category. Category 1 contains codes for the procedures in the 6 major fields of healthcare. Category 2 contains supplementary codes that may be used to add or track data and are often used in performance management. Category 1 CPT codes are 5 digits long and entirely numeric. Category 2 is alphanumeric, but we'll focus our attention on Category 1 here. Category 1 is divided into 6 sections, each corresponding to a major field of medicine. The sections are evaluation and management, anesthesiology, surgery, radiology, pathology and laboratory, and medicine. These sections are, for the most part, ordered numerically. Evaluation and management is out of order and placed at the front of Category 1 for ease of access. E&M codes are used frequently by most practices. Each section in Category 1 is broken down into further subsections. For example, the surgery section is subdivided into sections based on where on the body the surgery is performed. Those subsections are then further divided by what kind of surgical procedure. An incision versus an excision, for example, is being performed. Many Category 1 CPT codes are procedures that are based on a general parent procedure. The parent procedure is often a basic or simplified version of the procedure, while the codes indented below it describe variations on the procedure that are too specific to be included in the parent code. Let's look briefly at Category 2 and 3 codes. Category 2 codes are optional codes that are added to Category 1 or Category 3 codes. Category 2 codes describe things like patient management, patient history, and the results of certain diagnostic or screening tests. Category 2 codes are supplemental and may never take the place of a Category 1 or Category 3 code. Category 3 contains temporary codes for emerging and experimental procedures. CPT is updated annually to keep up with new and emerging medical procedures and technologies, and Category 3 is a place where new procedures go for their test run. Before a procedure can be added to Category 1, it needs to be performed a certain number of times by a certain number of different providers. Category 3 is where the codes that are not yet official but are being tested out reside. CPT modifiers. CPT modifiers are an important part of coding with CPT. These 2-digit, entirely numeric modifiers are added to the end of a CPT code with a hyphen and may describe the what, the who, the where, and the how of a particular procedure. There are modifiers for things like multiple surgeons, discontinued procedures, and increased procedural services. These modifiers are integral in the reimbursement cycle as they tell the payer that a provider had to work more or less during a particular procedure. Because these modifiers can be very important to the billing process, we order them in such a way that the most important or functional modifier goes first. That is, if there is a modifier for increased procedural services, -22, and one for bilateral procedure, -50, we'd code the -22 modifier first, as it tells the payer that the provider had to perform extra work. The reason for this is simple. Despite the fact that most claims have room for up to 4 modifiers for each procedure, many third-party payers sometimes ignore modifiers after the first 2. For this reason, it's important the modifiers directly related to the reimbursement cycle come first. Healthcare Common Procedure Coding System, HCPCS. The final of the 3 critical code sets used by medical coders is HCPCS. Developed by the Center for Medicare and Medicaid Services, CMS, HCPCS is a primary way that billers describe procedures to Medicare, Medicaid, and a host of other third-party payers. HCPCS is based on CPT, so much so that the first section of HCPCS is identical to CPT. It's a bit technical, but when you use CPT but submit it to Medicare, Medicaid, or one of the third-party payers that accepts HCPCS, those CPT codes become HCPCS codes. You don't have to enter anything differently. Since the code sets are the same, payers simply recognize Category 1 CPT codes and Level 1 HCPCS codes as interchangeable. The code sets diverge with HCPCS Level 2. HCPCS Level 2 describes the various non-physician services administered or prescribed by healthcare providers that aren't covered in CPT. It's a broad swath of codes, so broad that HCPCS is sometimes referred to as the hall closet of medical coding. It's got a little bit of everything in there. These codes are 5 characters long and alphanumeric. The code set is divided by area of focus and assigned a letter, which doubles as the first character of the code. For instance, B codes are for enteral and parenteral therapy, E codes are durable medical equipment, P codes are pathology and laboratory, and so on. Level 2 codes include dosages of non-orally administered medicine, like injections, and each specific type of splint, so the code is extremely specific. Coders use HCPCS Level 2 just as they would CPT. If there is equipment, certain professional services, injected medication, or any number of things listed on the report that aren't found in CPT, the coder should use HCPCS Level 2. HCPCS modifiers. Like CPT, HCPCS has a set of 2-character modifiers that provide important additional information about the code. These modifiers are added to the end of either CPT or HCPCS Level 2 codes with a hyphen. You may use HCPCS modifiers alongside CPT codes and CPT modifiers. You can tell whether a modifier is a HCPCS or a CPT modifier quite easily. CPT modifiers are always numeric, and HCPCS modifiers are always alphanumeric. There are significantly more HCPCS modifiers than CPT modifiers. HCPCS modifiers may describe everything from the type of ambulance service performed to the location on the body a procedure was performed. Bear in mind that certain HCPCS modifiers do not agree with certain CPT modifiers. The most common of these mutually exclusive relationships is the HCPCS modifiers -LT and -RT, which describe which side of the body a procedure is performed on, and the CPT modifier -50, which describes a bilateral procedure. Obviously, something can't be performed on the left side of the body and be a bilateral procedure. As with CPT modifiers, coders should always order functional HCPCS modifiers first and informational modifiers second. That concludes our review. Before taking the review quiz, feel free to re-watch any course videos and look at our downloadable materials for extra information.